Hello everyone, my name is Ashton Millette, and I'm going to be speaking about the challenges within psychiatric hospitals and the potential for improvement through interior design. The state of mental health care is a pressing issue that has affected our society for generations. Upon beginning my research, I found that facilities are often left providing the bare necessities in regard to design. In doing so, key environmental elements are diminished, which can drastically impact an occupant's overall health. Psychiatric facilities are provided as a form of treatment for patients with acute to severe mental illness symptoms and should reflect an atmosphere that advocates for their well-being. This may be achieved in a number of ways, and while we are not focusing on the primary solution throughout the duration of this presentation, it is always important to lay a solid foundation in understanding our concept. When looking at the current institutional design, facilities such as general children's hospitals, surgical spaces, and dental practices have utilized styles such as design for healing in order to achieve efficient spaces that reflect the relationship between environmental elements and a patient's recovery. While mental and physical illnesses or traumas differ from another, this form of design can make substantial changes regarding patient and staff experience within psychiatric care. In order to work towards a solution with any problem, it is important to recognize the root of it. When looking back to the history of psychiatric care, facilities began to open in the 1700s through the help of Philadelphia Quakers. Beforehand, individuals with mental illness had limited options, as many were left being cared for by family or placed in almshouses and jails. As religion played a significant role within our society, many believed that mental illness was a form of punishment for spiritual failings. This, along with an increase in population, ultimately led the Quakers to pursue their endeavors. As recognized in the examples, early psychiatric facility structures were designed to reflect Shaker-style architectural features and values. This is seen through details such as symmetrical windows and door placement and minimal orientation. Following, values and codes of behavior were reinforced throughout the structures by segregating spaces based on gender and dividing up the facility with smaller spaces and private spaces and then central environments for the group together. This was done as it was believed to improve efficiency and also commonly used in early penitentiaries. Early facilities attempted various structural plans in hopes of improving living conditions. This includes plans such as radio corridor, pavilion, and more. Despite these efforts, however, each introduced negative drawbacks in the process. For example, you can see the layout of the radio plan depicted in Figure 3, as the central point in the center and the corridors spread from it. Though this plan emphasized surveillance, it significantly decreased the amount of natural light let in and overall air circulation. Upon creating the corridor plan in 1830, the central point of the facility remained in the heart of it, with one wing extending along each side. This improved communication and had the potential to improve lighting, as the building was no longer blocking itself. However, to accommodate the loss of space when removing the other corridors, rooms were placed along each side of the facility, thus remaining ill-lit. Along with poor environmental quality within the facility, living conditions only got worse within the following years. This is particularly recognized within the 20th century, as there was a substantial increase in diagnosed cases. By 1955, over 588,000 patients overcrowded psychiatric facilities in America. With ill-equipped staff and inflexible space, patients were subjected to violence, neglect, and poor sanitized environments. Ultimately, these inhumane living conditions played a part in the deinstitutionalization movement. In short, this movement is recognized as transferring patients with mental disorders or developmental disabilities from long-term institutes to community-based health services. Other elements that helped push this movement forward was the advancement in psychiatric drugs as opposed to enforcing radical forms of treatment, as well as the shift in societal views. Ultimately, this led the federal legislation into reconsidering and passing the Medicaid Act in 1965, which meant the funding would be moved from state-owned facilities to community-based treatment. When describing the effects of deinstitutionalization, it's best to describe it as a double-edged sword. On one hand, it protected the civil rights of the mentally ill and helped diminish inhumane facilities. On the other, with insufficient services, resources, and staff to support individuals within their community, and many individuals face risk of homelessness, substance abuse disorders, suicide, and incarceration. Upon looking at the research available by the National Institute of Mental Health and the Centers for Disease Control, 1 in 5 or 45 million adults in the U.S. are living with mental illness or developmental disorders. Following 1 in 5 or 15 million children under the age of 18 are also struggling with mental, emotional, and behavioral disorders, 12 million of which will never receive treatment. When breaking down how this impacts the American population, suicide rates have risen 28% since 2000. 1 in 5 homeless individuals struggle with severe mental illness, and 57% of inmates have shown symptoms or have a history with mental illness. Following, 25 to 40% of individuals with mental illness are subjected to incarceration at some point in their lives. These numbers reflect our current mental health care system, as the deinstitutionalization movement has drastically cut down on the number of beds available for psychiatric services. Without having adequate alternatives or proper facilities, patients with severe symptoms can have a difficult time integrating into society, which can lead to chronic homelessness or inappropriate placement into our correctional system. Aside from acknowledging the root of the issue and the relevance of finding a solution, it is also important to briefly discuss the role of interior design within the bigger picture. Ultimately, designers take into design theory and environmental elements in order to establish spaces that positively impact an occupant's physical and psychological well-being. This is done by addressing visual communication such as color, proportion, and space, as well as considering details such as wayfinding, privacy, air quality, and ergonomics. By recognizing such issues within an environment, designers take part in solving various challenges. When looking at the function of the facility, they are commonly provided to individuals who are struggling with severe or intensified symptoms, as other forms of treatment have remained ineffective. They strive to stabilize, diagnose, provide and adjust appropriate prescription medications, and then coach the patient on various coping techniques. Along with individual therapy sessions and self-reflection time, patients are expected to participate in group sessions and activities as well. While this should be an effective process of helping patients cope and integrating them back into society, care can be less than ideal for some. For example, Noam Spencer, a professor at Ottoman College, discusses his niece's experience with psychiatric facilities with Psychology Today. After admitting herself for hallucinations, stress, and anxiety, she was met with very little information regarding wayfinding, discharge procedures, rules, medications, and more. The bulk of her time was spent doing mindless activities rather than receiving the help she desired. It took almost 35 hours before seeing a mental health professional and 10 minutes before she was directed out of their office, meaning she did not receive the proper diagnosis, prescription, or information regarding coping techniques. Following, she was misplaced in a group that had nothing to do with her case and threatened for acknowledging the mistake. While their case does not reflect psychiatric care as a whole, it does speak volumes regarding the consideration provided for inpatient treatment. When looking at the overall atmosphere and examples provided, you can see the psychiatric facilities commonly reflect institutional design. Following, many of the spaces are smaller with little access to natural lighting and contain unflattering finishes and furnishings that do nothing to reflect a positive environment. Following, harsh fluorescents are heavily relied on throughout the duration of the facility. Though institutions should always emphasize sanitation, psychiatric facilities also need to provide a comforting atmosphere for their patients. Many of the selections within common institutes are unnecessary and even hurtful at times in psychiatric facilities. Following, space planning should also be addressed when designing these facilities. For example, many patients should gather around central points, such as nursing stations. If there is an inadequate amount of space to accommodate them, it can cause traffic issues. Jan Rosenberg discusses these issues within psychiatric design through exploring patient and staff perceptions. In doing so, Rosenberg evaluates 640 staff members and 442 patients among 42 facilities. She then determined that while the environment has a greater impact on patient satisfaction, it does contribute to employee efficiency. Ultimately, while designers do not have the ability to change external issues, they do have the tools and education to provide environments that advocate for a patient's well-being. Thank you for your time, and I appreciate your feedback.